The committee will come to order, and good morning to everyone, and thank you for being here this morning, especially this hearing to examine the United States' contribution to the global fight against malaria. Leadership matters. In 2005, President George W. Bush established the President's Malaria Initiative, or PMI, and targeted several African malaria endemic countries to receive over $1 billion to mitigate and someday eradicate this killer disease. The positive consequences of that bold and compassionate initiative now includes over 1 million lives saved over the last decade. And of course, the program and its expansion and sustainability of the funding has been all important in that battle. Although we will hear statistics about malaria cited several times during the course of this hearing, the global impact of this disease is so severe that they are worth repeating, and I say that even though we are making progress. The World Health Organization estimates that in 2010, there were 219 million malaria cases and 660,000 deaths. While still unconscionably high, every life is absolutely precious and of extraordinary importance. Loss of life has declined from approximately 985,000 deaths in 2000. Not surprisingly, malaria has a particularly devastating impact on the most vulnerable. Nearly 86% of those who die are children under 5 years of age, living in sub-Saharan Africa. Dr. Mark Dybul, Executive Director of the Global Fund to Fight AIDS and George W. Bush's extraordinarily effective Global AIDS Coordinator, says that in Africa alone, malaria takes a life of a child every minute. He also notes, as do our other panelists, that pregnant women are also disproportionately malaffected with the disease. WHO emphasizes in its World Malaria Report in 2012 that malaria is strongly associated with poverty. Countries in which a larger percentage of the population lives in poverty also have a higher mortality rates from malaria. Children living in poorer populations and in rural areas have the highest parasite prevalence rates. It is also important to note to the extent to which the prevalence of malaria is concentrated. 80% of malaria deaths occur in just 14 countries, and almost 80% of cases occur in 17 countries. Over 40% of malaria deaths occur in just 2 countries, the Democratic Republic of Congo and Nigeria, and 40% of the malaria cases are in the Democratic Republic of Congo, Nigeria, and in India. These high morbidity and mortality rates are not necessary. Malaria is both preventable and treatable. We will hear today from our distinguished witnesses who are leaders in the field about the cost-effective measures that are currently available and already having a profound impact or are in the development process. And the United States, despite the current financial constraints, is making a significant contribution to the global fight against malaria. In addition to our contribution to the Global Fund to fight AIDS, tuberculosis, and malaria, the United States provided $871 million in anti-malaria assistance in fiscal year 2012 alone, and the request for fiscal year 2014 is $893 million. But these levels, even when combined with contributions from other donors, do fall short of the global need. So our question today will be, what are the major challenges going forward, and how can we best use our resources to meet those challenges to save the most lives and have the greatest impact in controlling, if not eradicating, this dreaded disease? We will also be taking a close look at several immediate threats to global efforts to combat malaria. On April 19th, this subcommittee held a hearing on, quote, meeting the challenges of drug-resistant diseases in developing countries. In his testimony at our hearing, Dr. Thomas Frieden, director of the Centers for Disease Control and Prevention, warned that in recent years, malaria infections in parts of Southeast Asia have been showing resistance to artemisinin drugs. These drugs are the last remaining class of antimalarial drugs and form the basis of malaria treatment globally. If these resistant parasites manage to spread to sub-Saharan Africa, he stated that the results could be, quote, devastating an assessment that will likely be repeated by our witnesses today. Insecticide-treated nets, bed nets, which have an average useful life of 2 to 3 years, are also an extremely important proven malaria prevention tool. According to WHO, 150 million nets are needed each and every year to provide protection to the vulnerable populations in sub-Saharan Africa. For the past 2 years, however, the supply has been considerably lower than this level, resulting in an estimated current shortfall of 77 million nets. The consequences, if not urgently addressed, could place entire populations, especially children, at risk of a dramatic malaria resurgence, and of course that means more death and more morbidity. We are fortunate, again, to have 3 distinguished experts who will provide us with valuable insights. These are truly leaders in the field, and I do hope, C-SPAN is here, and we are grateful they are here. I would hope that Americans would sit back and take note of the extraordinary work you 3 individuals are doing. People sometimes are very dismissive of foreign aid and initiatives that taxpayer funds are used. This is one of the greatest success stories. It's not the only one, there are many, but this is one of the greatest success stories, but it's a work that remains unfinished. And again, so I thank our witnesses for being here and for being such leaders. I'd like to now yield to Mr. Burr.
Thank you, Chairman Smith, and thank you for holding today's hearings and the series of hearings on global health, incredibly important topics. And I look at this from the perspective of being a doctor who's worked internationally, and the work that you guys are doing is incredibly important, and I look forward to hearing your testimony. As has already been mentioned, there are over 219 million cases of malaria worldwide. The Democratic Republic of Congo, India, and Nigeria account for 40% of all malaria cases. Those cases account for over 600,000 deaths in 2010. Very preventable. So this is an incredibly important issue. Like so many other diseases, with the right policy, with the right partnerships, we can save hundreds of thousands of lives. Unfortunately, far too often these tools are not reaching those in need, and I'm looking forward to hearing the testimony of best practices and how we get the therapies and the prevention and the nets out to those where we can make the biggest difference. While malaria continues to take the lives of children and adults, we also have seen the international community coming together and some great demonstrations of remarkable success. The Global Fund, the President's Malaria Initiative, the Gates Foundation, the World Health Organization, just to name a few, have helped reduce unnecessary deaths in Africa by an estimated 33% in less than a decade. We can still do better. The fund has 779 active grants, 217 of which are for malaria. It's approved almost $7 billion, or 27% of its funds in the fight against malaria. Since 2000, malaria mortality rates have fallen by more than 25%, and 50 countries are on course to reduce malaria incidence by 75% by the end of 2015. These are efforts to be applauded. Again, I look forward to supporting and doing more. Chairman Smith has done an excellent job laying out the profound challenges that we face in fighting malaria. I would like to share with the committee just a couple success stories over the course of testimony, and I certainly look forward to hearing the success stories and the best practices. In addition, today we don't have a vaccine that prevents someone from being infected with malaria, but I'm here to say, as a research scientist, as a physician, there's nothing that we can't do in this country and in our academic community if we set our minds to it. And ultimately, that's where we need to go if we want to truly prevent disease and save lives. So, thank you for being here. Thank you for the testimony. I look forward to hearing from each of you. And, again, Chairman Smith, thank you for calling this important hearing.
Thank you very much. I'd like to now yield to Mr. Weber.
Thank you, Mr. Chairman. Very important topic. I appreciate the opportunity to be here and to have this hearing. My dad, one of the last of the greatest generation, 88 years old, served in the Philippines, contracted malaria. To this day, cannot give blood. He has the rarest blood type there is. 0.5% of America has AB negative, which is what I have. Now you know what's wrong with me. But just a great guy. I try to give blood as often as I can. And so it's very, very important because that keeps those who contract the disease from giving blood, and I think it's very vital. So appreciate being here and looking forward to the testimony. Thank you all.
Thank you very much, Mr. Weber. I just know parenthetically that my father, too, served in World War II in New Guinea, and he was a combat infantryman, and he got malaria, and my family was very well aware of the impact it had on him as well. So thank you. I'd like to now yield to Mrs. Cicilline.
Thank you, Chairman Smith, and thank you to you and Ranking Member Bass for holding today's hearing on the role of the United States in the fight against malaria. And I want to thank my colleague and friend, Congressman Barra, Dr. Barra, for his leadership on this issue and on issues of global health in general. This remains a serious worldwide public health emergency. The World Health Organization estimates that 219 million cases of malaria worldwide, with 660,000 malaria deaths. So this is still an urgent issue. I want to begin really by offering my gratitude to the witnesses, not only for being here today and for your testimony, but for your incredible leadership and the work that you have led that is making a real difference all across the world as we combat the scourge of this disease. Our country, the United States, has a vested interest in addressing health conditions around the world in order to improve lives, to strengthen the economies of our trading partners, and to maintain our moral leadership position in the world. I think it is concerning to all of us that malaria remains a leading cause of death in many countries, especially when we've made such astonishing gains in health care here at home. And I hope that the United States will continue to support the funding of global health development as we transition to country ownership and eventually eradication of this disease, and that we continue to value the work of the Global Fund to fight AIDS, tuberculosis, and malaria, the Gates Foundation, the President's Malaria Initiative, and to just note that these are, as Chairman Smith said, great success stories of what our role around the world has been when we make the right kinds of investments, and these have been bipartisan efforts, and I know they will continue to be, and I thank the Chairman again and yield back.
Thank you very much. I'd like to yield to Mr. Meadows.
Thank you, Mr. Chairman, and thank you to each one of you for your service to our country. We appreciate it. We're here, obviously, today to address a disease that's been a scourge on humanity for almost our entire history. And as we've been fighting malaria for a very long time, it's encouraging to see how far we've come, but also what's left to be done. And so I look forward to your testimony today. We've seen malaria generally eradicated in the developed world, but yet there's still a lot of work to do. As you know, some 80% of malaria deaths occur in just 14 countries. And as we see that, we've got 80% of the cases, 90% of the deaths occur in Africa. And we've learned over the past 60 years that eradicating this disease is an ongoing challenge, requiring multiple efforts, working in concert, and there is no magic bullet to do that. We heard testimony even in this very room under a hearing that the chairman conducted from the CDC, offering some of the challenges that we face with different strains that are resistant to even the drugs that we have today. And so I'm encouraged by Dr. Barra. We've teamed up on a number of bipartisan initiatives to try to work on finding some of those solutions. And so I look forward to hearing your testimony. I'm proud of the role that the U.S. has played in this ongoing struggle. It's really been our leadership that has really worked very well, and I'm mindful that that does not mean that we can, abdicate our duties to be good stewards of the taxpayers' money either. And corruption cannot be tolerated in any manner. I've traveled a number of times to Africa, and when you start to see the lack of accountability in certain areas, it gives you great concern. And so part of the reason for holding this hearing is so that we remain vigilant and that we work against the bad actors that we have to deal with, but also that we encourage others and those that are suffering, certainly that we come to their aid. This would include pressuring local governments and making sure that we we have the encouragement there that not just from an oversight standpoint, but to make sure that what we do is that the American taxpayers' dollars are invested wisely. When we do that, there is always a drawback. When I go back home, there is a consistent, why are we giving aid? We have people that are hungry and out of work here. Why are we doing that? And obviously this and so I would look for some of the testimony in really what it might do in terms of our men and women that serve and some of the things that we have in terms of challenges, not just from a global perspective, but as we bring that back home. And so I would look for each one of you to hopefully address that. Fiscal year 14, we look at both in USAID and the CDC have both requested increase in their funding as we see that. And what I would love to see from you is how I can make sure that we put forth and share with the voters back home that not only are we being wise stewards, but that we're being accountable and we're doing the very best that we can to make our money go as far as we can. The growth of public-private partnerships, the encouragement there, some of the work that we've already seen there, I applaud that. In recent years, we've seen that, the President's Malaria initiative, working with the World Health Organization and other institutes using the federal dollars to be leveraged in that private-public partnership in a real way. And so I just applaud you on the work you've done. I'd love to hear so that we can share with those that in these tight fiscal times how we're managing that properly, and perhaps what we can do from an oversight standpoint to make sure that not only are we investing wisely, but that those funds meet the real needs that are there. But I thank you, and with that, I yield back, Mr. Chairman.
Thank you very much, Mr. Meadows. Mr. Stockman.
In the course of building the Panama Canal, as you probably recall or from your history, and they had to address first the health problems there. And when I was over at the Democratic Republic of Congo, DRC, I think they have a similar circumstances. Some of the health issues are holding back their productivity and their production and GDP. But I believe that even the great expanse they have made, they still need help in that area. When I was over there, I noticed they were selling some of their mosquito nets. So I'm looking forward to your testimony, find out if there's alternative ways besides just mosquito netting. And appreciate all the efforts that you have done and continue to do on behalf of the United States. And I think this sends a large signal to the rest of the world, just the compassion of the Americans. And I yield back my time, Chairman. Thank you.
Thank you very much, Mr. Stockman. I'd like to now introduce to the panel our two first witnesses. Rear Admiral Tim Ziemer was appointed in June of 2006 to lead the President's Malaria Initiative, a $1.2 billion 5-year initiative to control malaria in Africa, which was expanded through an authorization in the 2008 Lantos-Hyde Act. Admiral Ziemer was born in Iowa but raised in Asia, the son of missionary parents serving in Vietnam. After graduating from college, he joined the Navy, completed flight school, and returned to Vietnam during the war. During his naval career, Admiral Ziemer commanded several squadrons and naval stations and an air wing supporting the first Gulf War. Prior to his appointment at PMI, he served as executive director of World Relief, a humanitarian organization, and has had a distinguished stint as leader of the President's Malaria Initiative. And those of us on this committee are very well aware of the great contribution you have made and the leadership you have provided. We'll then hear from Colonel Peter Wino, who is assigned to the Walter Reed Army Institute of Research, where he serves as deputy commander. He leads many medical initiatives in the Army, and his works have been published extensively in journals and books. Colonel Wino is a recognized expert on numerous diseases. He was the lead behind the availability and licensure of a life-saving drug for the treatment of severe malaria throughout the United States and Canada from 2002 to 2009, an effort that was recognized by CDC Silo Busters Collaborative Award of Excellence in 2008. Among his many other impressive awards, he is a recipient of the Bronze Star for service in Iraq during Operation Iraqi Freedom. And without objection, your full resume shall be included in the record. So I'd like to yield to Admiral Ziemer.
Chairman Smith, members of the committee, it's a pleasure to be back before you today. Before I begin my testimony, I would like to take a moment to acknowledge and express my appreciation for Congress's ongoing and steadfast support for malaria control. The global fight is succeeding. Deaths have decreased by 1/3, with bipartisan support in Congress for both bilateral and multilateral efforts through the Malaria Initiative and the Global Fund. Malaria is being rolled back. It's a triumph of partnership, all of us working together, the U.S. government, our partners, host countries, and the communities we are trying to serve. We simply would not be seeing the impact we're seeing today without your support and commitment. Thank you very much. The United States Malaria Program through the PMI continues to be a game changer. In the 7th year of the initiative, the financial and technical contributions made by the United States government are the major catalyst in the remarkable progress that has been achieved in many countries to reduce the devastating burden of malaria on child mortality. At the same time, with the U.S. government's support, countries are also strengthening their own capacity to fight this disease. PMI at its very core is an example of success and real impact that the United States government can achieve through a solid interagency partnership. Through PMI, the core strengths of both USAID and the Centers for Disease Control, and indeed across the entire U.S. government spectrum, Walter Reed, DOD, the NIH, as well as the Peace Corps. It's a tremendous success story, yet it is still incomplete. I just returned from Uganda, and despite the recent progress, malaria remains the largest killer of children. In the midst of these tragic statistics, we have some good news. This year, with 21 million insecticide-treated bed nets provided by the Global Fund, the U.S. government, DFID, World Vision, and other partners, the government of Uganda is poised to make real and substantial gains against malaria. Seeing children suffering from malaria, I'm reminded of my childhood days in Vietnam. My parents, as was indicated in the opening statement, were missionaries there. I was fortunate to sleep under a bed net, and yet I caught malaria. I was fortunate to have anti-malaria medicine to cure the disease. Every child in a malarious part of the world should be protected, as I was. In the last 7 years, substantial reductions in mortality among children under 5 has dropped 16 to 50% in 12 of our original PMI countries. Although multiple factors may be influencing the decline in under 5 mortality rates, strong and growing evidence suggests that malaria prevention and treatment are playing a major role in these unprecedented reductions in mortality. PMI is participating in in-depth evaluations to ascertain the contribution of malaria control efforts to these reductions in mortality, with Tanzania being the first country to complete this evaluation. 63,000 lives have been saved over a 10-year period because of the scale-up of malaria interventions. In 2011, PMI commissioned an external evaluation team to review its performance. The evaluation affirmed that PMI's planning, implementation, partnerships, and funding have been key to the global efforts to combat malaria. The evaluation team made 5 policy and 5 technical recommendations that will guide programmatic improvements over the next years. PMI views these recommendations as relevant and useful for program improvement. We've come a very long way since the inception of the Global Fund in 2002 and the creation of PMI 3 years later when President Bush committed $1.2 billion for malaria control. The initiative started with Tanzania, Uganda, and Angola. Since then, 16 additional focus countries have been added, with 3 non-focus countries. In addition to the bipartisan support of Congress, PMI benefited from the full support of President Bush and First Lady Laura Bush, and now the Obama administration. In 2010, President Obama launched his vision for how the United States would approach global development, which sees development assistance as a pillar for foreign policy and is crucial to America's national security and economic interests. In his 2013 State of the Union address, President Obama framed 2 goals: that the United States will join with our allies to eradicate extreme poverty in the next 2 decades, and saving the world's children from preventable deaths. Malaria is a major cause of child mortality in Africa, and consequently, preventing and controlling malaria are a key focus of the U.S. government foreign assistance program. PMI is playing a lead role in implementing the President's vision. Partnership is the hallmark of how PMI does business. Partnership with host countries, other donors, the private sector, and nonprofits and faith-based groups underpin our success. PMI has supported malaria activities through more than 200 nonprofit organizations. Approximately 1/3 of those are faith-based. These groups often have strong and effective bases of operations in underserved rural areas where the burden of malaria is the greatest. The Global Fund and PMI's commitment to effective coordination is maximizing our impact on the global malaria burden. Each program has its own unique strengths, lending to the complementarity of the partnership and significant successes on the ground. Currently, all 19 PMI-focused countries in Africa and the greater Mekong subregion receive substantial funding from the Global Fund. Because of the strength of our in-country technical staff, we support the effective implementation of Global Fund programs. While the risk of malaria is declining and more children are surviving, the gains are fragile and could be reversed without continued support. We recognize and appreciate the continued commitment of Congress and the American people to fighting malaria through PMI and the Global Fund in this time of budget austerity. The goal is to continue to shrink the malaria map and to ensure successes are rolled back, not rolled back, even as the dual threats of artemisinin and drug resistance and insecticide resistance is growing. A strain of the malaria parasite has appeared in parts of Southeast Asia with resistance to the most effective medicines to fight the parasite. And some fear that the parasite might ultimately become resistant to all drugs we currently have to treat malaria. The emergence of this resistant parasite to Africa would be devastating. We must also be diligent in identifying and monitoring mosquito resistance to insecticides so that our most effective prevention measures, insecticide-treated mosquito nets and indoor residual spraying, aren't undermined. If mosquitoes become resistant to those insecticides, the efficacy of the interventions will be compromised. Tackling these new strategic challenges is a priority, and we are working with the private sector to develop new anti-malaria drugs as well as insecticide-based tools. At the same time, we must continue to expand our toolbox by developing a highly effective, inexpensive vaccine that could result in hundreds of thousands of lives saved. So in closing, I'd like to thank the U.S. Congress for its continued support and to reiterate that together with our partners, we remain deeply committed to the global fight against malaria. Thank you, and I look forward to your questions.
Admiral Ziemer, thank you very much for your testimony and again for your leadership. We do have a vote, 2 votes on the floor, and I apologize for the inconvenience to our witnesses. We thought we'd take a very brief recess, come back, and Colonel, then we'll receive your testimony, because we really do want to hear what you have to say. So the subcommittee stands in recess. The subcommittee will resume its sitting. And Colonel Wanu, if you could proceed with your testimony.
Thank you, sir. Chairman Smith and distinguished members of the subcommittee, thank you for the opportunity to appear before you to discuss the Army's medical research initiatives to improve soldier readiness and global health, and highlight the incredible work of the military medical research community. I extend our appreciation to Congress for the support to military medicine faithfully given, which provides the resources we need to deliver leading-edge health services and diligently continue innovative research. Malaria is a global ancient scourge that has haunted mankind for much of our history, and yet it still impacts our lives and our society today. I know it's been said many times, but it bears repeating. Over 3.3 billion people remain at risk for the disease. Over 200 million cases of the disease appear every year, along with over 650,000 deaths. Among the most vulnerable are the young children, who account for over 85% of the malaria-related mortality globally. A preventable disease, malaria is a leading cause of death in children under 5 years old in sub-Saharan Africa. The U.S. military has also felt the threat of malaria as far back as 1775, when George Washington expended limited resources to purchase quinine for the treatment of malaria. Malaria has been diagnosed during the Civil War, World War II, Vietnam, and even recently in Afghanistan. Historically, the incidence depends primarily on deployment location, but during the last 10 years, we have seen approximately 100 cases every year, despite the resources we have to protect our troops. While the days of massive debilitating impact on malaria operations are behind us, we only have to look back to 2003 in order to appreciate the potential impact when a military peacekeeping operation in Liberia failed after only a few weeks due to 80 cases of malaria in 225 Marines, 44 of those requiring medical evacuation. The destabilizing effects that diseases such as HIV and malaria have on the critical infrastructure of developing nations is compelling evidence that global health is a means to global security. These diseases undermine the education and health systems, economic growth, micro-enterprises, policing and military capabilities, political legitimacy, family structures, and overall social cohesion. They undermine the stability of already weakened states and add to their vulnerability to extremists and terrorists who seek to corrupt or coerce. Our response through medical engagement needs to be comprehensive, fought at many levels and on many fronts to provide for global stability and our own nation's security. The Walter Reed Army Institute of Research has a trusted partnership in several countries that has been established for decades. Long-term relationships have been built with host countries as well as health organizations, allowing both personnel and logistical support to establish larger work. We have been in partnership with the Royal Thai Army for over 50 years and with the Kenyan Medical Research Institute for over 40 years. We have established robust relationships that have allowed the important work of military medicine's research as well as the important work of PEPFAR and PMI. The U.S. military's exceptional science, logistic, and regulatory expertise allows for the testing of new products to the best standards of care for the local population, as well as the delivery of critical life-saving HIV and malaria interventions. Military medicine also serves as a partner in the critical platform of disease surveillance. Both the Army and Navy conduct overseas disease surveillance operations that not only keep a watchful eye on malaria patterns and malaria resistance throughout the world, but also survey for other infectious disease threats. These overseas operations are part of a complex ecosystem that provides not only surveillance, but also a platform for testing new products, medical engagement with many countries worldwide, and outreach for the execution of PEPFAR and PMI missions and programs. Vigilance and combating malaria is an enduring mission. The U.S. military is engaged in malaria research for several key reasons. to preserve the fighting strength of our men and women in uniform who go into harm's way, to protect our nation's citizens who encounter these threats worldwide, and to positively impact the global health and stability of our allies. In closing, I am proud of the global impact that military medicine research has done throughout history, and the continued diligence being done to combat one of the oldest infectious disease threats man has known. In partnership with the Department of Defense, my colleagues here today, our global partnerships, and the Congress, we will be prepared for tomorrow's challenges. Thank you for your time.
Colonel, thank you very much for your leadership and for your testimony today. Just to lead off the questioning, let me start off with a question to Admiral Zimmer. You mentioned about 1/3 of the NGOs that are getting assistance happen to be faith-based. One of the concerns that I've expressed from the very beginning, both with PEPFAR and malaria and every other U.S. foreign aid program, especially as it relates to Africa, has been the early exclusion of faith-based organizations, primarily because of ideological reasons. But there appears to be, and I think there's been good, strong support for this. I actually wrote the conscience clause for the PEPFAR program because of that exclusion. And if you could just elaborate a bit on how, especially indigenous faith-based groups are being included. If we want to end the pandemic of HIV/AIDS, it seems to me, TB, the problems associated there, and of course, the malaria problem, we need to have as partners those faith-based groups. If you could touch on that.
Yeah, thanks for the question. When PMI was launched, one of the first things we did was to look at the best practices of PEPFAR and modeled some of our programmatics after the PEPFAR model. So to the extent that there were clear guidances coming from here and from the administration, we looked at them and embraced them. But I can tell you from the beginning of PMI, we intentionally looked at a deliberate engagement of the NGOs in the field, specifically looked at the merits of the faith-based organizations because we acknowledged, and from personal experience, accepted the fact that they were there before we got there, and they'll be there after we go. And when we start embracing capacity building and sustainability of programs, the local NGOs, specifically the faith-based, are a huge component of building for the future.
Appreciate that. You know, the impact on childhood cognitive development, we know that obviously our goal is to eradicate malaria and to prevent deaths, but also to mitigate morbidity and other consequences like the impact on cognitive development. What happened, is the timeliness of the intervention key? We know that with, I chair the Lyme Disease Caucus here in the House and have a bill pending that I hope will get up on establishing a Blue Ribbon Commission on Lyme disease, particularly chronic Lyme. And the longer the parasite grows inside an individual, the worse its deleterious effects. And I'm wondering, the issue of how this malaffects children as they become adolescents, adults, and right on through the rest of their life.
You're asking a rather technical question, and I would defer that to some of our scientists and colleagues when it comes to the impact or delayed, the impact of delayed parasite clearance from a system. I do know that we have a very rigorous prenatal program so that when pregnant women go into the clinics, we're providing preventative treatment. So in terms of the health of the newborn child, it's being addressed through that prevention measure. But when a child presents with a fever, we're committed to appropriate diagnosis and then treatment. So at an early age, if the child presents and is diagnosed with a fever, we do everything we can to provide treatment.
In his testimony, Ambassador Dybel, the executive director of the Global Fund, points out that between 2004 and 2010, and the need, the coverage need, the level of need was essentially met. but only 92 million nets were delivered by manufacturers in 2011, largely due to funding constraints, and in 2012, only 66 million nets were produced. He points out that in February of this year, the Global Fund and WHO and other partners, and I'm sure that includes you and us, the United States, estimated that 77 million nets were needed to maintain coverage for communities that the Global Fund has previously protected. He also talks about, the big push to replace insecticide-treated nets in its new and interim funding grant streams, along with bolstering diagnostic and treatment needs. And bottom line, that between 2013 and 2015, there's a $3.5 billion gap. Now, I know the United States has been generous. It has been the leader. Is there more that we could be doing? I mean, can we be partners, Congress, in ensuring that that gap is closed?
The fact that we know what the gap is and we can have these numbers represents information that we didn't have 5 years ago. Right. So as we look at supporting the country's requirements, we're able to refine the net requirements and then collectively discuss at the funding level, the partner level, and at the national level how best to direct those resources. I think it's important to acknowledge that since 2008 and 9, our partners, along with the United States, have distributed over 300 million bed nets to sub-Saharan Africa, which represents coverage to close to 600 million people. I think the figure is 578 million. So we are making tremendous progress. As we look at those at risk, I think it's important to look at the full toolkit that we have. 4 of the interventions that we use are focused on prevention. Bed nets, of course, is one, along with indoor residual spraying. We are looking at country requirements, the most at-risk population groups, and moving forward with the funding that we have. So are there gaps? You bet. Are we dealing with them better? Yes. We just have to keep at it.
And if you could help us, I mean, we want to be advocates. I certainly personally want to make sure that all that can be done is done. I thought that, again, Ambassador Dybel makes an excellent point. Progress made or lose momentum. The reality is invest now or pay forever, which is a very strong and I think very declarative statement that we could make a difference, but funding is key, and obviously deploying those resources prudently is key. Colonel, if I could just ask you, your written testimony goes into some great length. Thank you for your oral testimony as well. You point out that the Walter Reed Army Institute for Research, along with a pharmaceutical company, has developed and is what is currently the world's leading malaria vaccine candidate. You point out that the product is currently in phase 3 clinical trials in Africa. If you maybe would touch on where in Africa. Is it Kenya, where we have the lab and the medical research collaboration? And how close are we to, actually developing a vaccine that is deployable?
Yes, Chairman Smith, the question of partnering with a drug company, we do partner with all of the time with some sort of commercial entity to make sure that our products go forward. None of the products that we actually produce are things that are necessarily borne strictly by the United States to move forward. The question of where this work is being done, it's the phase 3 trial is principally being done in Kenya right now, where we have our laboratory. This work is moved forward significantly, but of course the question of when are we going to have a vaccine is really tied up in some very significant details. First of all, the vaccine that we have right now is not a vaccine that absolutely protects an individual from getting malaria. The great thing about this vaccine, and this is why it's being pursued principally in Africa, is because of the fact that it reduces the mortality associated with the disease. This vaccine, just like a lot of other vaccines that we're having difficulties with, such as HIV, are things in which they don't naturally occur in nature. We don't have a situation like we have, for example, with chickenpox, in which maybe somebody gets chickenpox and then they aren't going to get chickenpox again. Those vaccines are the easy ones. Those are the ones that have already been developed. What we're trying to do is actually develop a vaccine for a condition that doesn't occur in nature, so it's a lot tougher to do. What we have been able to mimic is the fact that children that have repeatedly gotten malaria are at lower risk of dying from malaria than individuals that may get it the first time. And this is a real success. It helps reduce the mortality, and it produces some information for us in possibly moving forward into a vaccine that does have significantly more efficacy and something that may actually prevent somebody from getting infected.
Let me ask you, Colonel, if I could, you point out that funding for malaria research and development in the military has been suffering since Vietnam. You talk about how you have worked very creatively, partnering with others to try to lessen the impact of that diminished funding, and I think $10 million is what you have in use for research. You also point out that resistance is a fact of drug development, and even the most cautious of drugs with the organisms we are fighting will always find a way to defeat our treatments, which is a very ominous statement and a very disconcerting statement. And we know in some 4 countries in Southeast Asia, and Dr. Frieden was very emphatic on that when he appeared before our committee just a few weeks ago, there's concerns about drug resistance to artemisinin. Could you speak to that issue of drug resistance and also that budget for research? What would more money enable you to do if it were to be available above the $10 million?
Yes, sir. The issue of resistance is something that we deal with not just for malaria, but for a lot of diseases. The malarial parasite is a very ingenious organism that is actually, I guess, just trying to survive. And we're constantly trying to beat it down. It has found a way of practically defeating every single drug that we have produced, all the way back to something that we've been using like quinine for over 300 years. All of the new drugs that are out there, mefloquine, Fansidar, all of these types of drugs, Malarone even, there is resistance. And our biggest tool in our arsenal right now are the artemisinin-based drugs. We are seeing an increase in the potential for resistance in Southeast Asia, particularly along the Thai-Cambodian border, where we've seen a lot of resistance arise. And we are going to, every single time we produce a new drug, these organisms are going to find a way around it, and that's why we need to have continued vigilance. That's why every single anti-malarial that has basically come out since World War II has had the involvement of the Walter Reed Army Institute of Research, because of the fact that we have continually worked on it virtually our entire existence, looking at a new drug. So every time we have a new one that's out there, we don't stop and celebrate that we have the new one. We're actually looking for yet the next one that's out there, and we have a full pipeline of drugs that are being developed and looking for yet that next generation, because we know we are going to have resistance, and there is no way of actually stopping that from moving forward. As far as the budget, I think everybody would just love to have more money. There are limited resources that are going to be available. I think what we would like to have, more so than anything else, is just to continue to get the money that we have been palmed. And that allows us to do the planning that's really necessary to move forward with our partnerships, because our people are very entrepreneurial. And whatever investment that the U.S. taxpayer puts into developing these drugs, we are able to partner with private organizations, with academia, with other government organizations, and really move the goal forward by bringing those types of partnerships together in this ecosystem that increases every single dollar 3, 4, 5 times and increase our budget to move things forward.
Would be concerned, not just, obviously, we're a brothers and sisters keeper, and that's what this program is built on, but there is the possibility, as you pointed out, of malaria being reintroduced into the United States. And I thought, there's something I never read in the history books when we talked about the Civil War. You point out in the 1860s, the Civil War saw 50% of the Caucasian troops and a staggering 80% of the black troops contracting malaria annually. That is extraordinary, and that's information that I think just underscores we had it here, it's gone. Now we have to hope and pray and work hard that it will soon be eradicated in Africa and everywhere else that it is. Mr. Burr.
Thank you, Chairman Smith. And I think the American public that if you're out there watching, you can be very proud of what we've been able to accomplish and the reflection of our values as a nation. The compassion, the humanitarian commitment to eradicating malaria, to the wonderful work that Admiral Zimmer and Colonel Wayna, that you guys have been doing, and the fact that this is a real bipartisan effort. The President's Malaria Initiative started under a Republican president and has continued under a Democratic president. The leadership demonstrated on this committee and the commitment to compassion and humanitarian need in eradicating some of the toughest diseases in the world. This is something that we can be proud of as an institution and as a country and nation. I look at this from the perspective of being a doctor, and the first course of medicine is always to try to focus on prevention of disease. And if you can prevent it, then you don't have to treat it. And we're making strides, and when we think about prevention of malaria, we think about obviously nets and preventing the mosquito bites. We also look at the public health measures that we can do, pools of water, et cetera, and educating a population where malaria is endemic. But Chairman Smith touched on the cornerstone of prevention in fighting infectious disease, which is vaccination. And if our goal is eradication, we really do have to focus on finding a vaccine. And Colonel, as you pointed out, malaria is a very smart challenge, and it's a smart parasite that has continually adapted. And yes, we're going to have to continue investing in the next generation of therapy, but until we can come up with an effective vaccine, it'll be very difficult to eradicate. I think you've talked about where we are on the vaccination side, and I would just reiterate, our commitment and my commitment as a physician and a member of Congress to continue to fight for that research funding until we do get that vaccine. You touched on the importance of partnership, and we do live in tight fiscal times. We do have a debt challenge here in this nation, and we're forever grateful for individuals like Bill and Melinda Gates who have stepped up philanthropically and have poured literally millions of dollars, billions of dollars into the fight to eradicate malaria. To either one of you, I would love to hear what you think are best practices in partnership, the role of the philanthropic and NGO community in helping us eradicate malaria, or at least hold it down and continue to make progress. And then the role in terms of capacity building in Africa, India, countries that are affected by malaria. So, whoever wants to take that question.
Thanks for that question. Let me just address a couple points. The USAID agency has been investing in vaccine research for over 40 years, and so it is a high priority, and we'll continue to focus in on that for the reasons you stated. On the prevention side, pleased to say of the 4 interventions that we use, WHO approved, 3 are prevention. And then we're scaling up case management, diagnosis, and then proper treatment. So as we continue to work with the countries, our focus is truly on the prevention side. A partnership in this austere time is actually very critical, and I'm really pleased to report that we're seeing significant progress made at every level. On the partnership advocacy piece, the work with the UN Special Envoy, Malaria No More, the UN Foundation, Nothing But Nets, the celebrities as well as the athletes are informing the American public about this disease And there has been a wonderful response collectively as American citizens to do something about that. So that's on the advocacy side. On the technical side, the fact that the Gates Foundation is totally invested on the high-tech end, and the governments and the multilaterals are invested on the countryside, we have a global malaria vision and plan to bring those two together. And so, again, over the last 4 years, we have something that we never have had before, and that is a vision, a strategy, and places for countries, donors, research folks to plug in to move us towards control, elimination, and eradication. One of the most important partners we have is the private sector. And I'm pleased to, and we can showcase and give you more details, but let me just give you 3 examples. In Western Ghana, we're partnering with Ashanti Gold through IRS. They're also funded by the Global Fund, the national government, as well as the U.S. government in looking at best practices and scaling up IRS. In Zambia, we're working with the copper mines companies to do the same thing. So let me just stop there. We are in, ExxonMobil is working with us in Angola, and their contributions directly into the program has been $4.5 million just for nets and the scale up of nets. So we can give you multiple examples of how we are seeing the partnership not only on the advocacy side, but in the planning and envisioning as well as the implementation side. I hope that's helpful.
Very helpful.
Yes, Dr. Barrow, the idea of partnerships is absolutely critical when it comes to combating any disease, and especially something that is as broad and as widespread as malaria is. I describe it as an ecosystem, and when one part of an ecosystem suffers, then the entire part of the system suffers. But there's also strength in that ecosystem so that when one part suffers, the other parts can help them out. The partnerships are critical, and the partnerships come at many different levels. There's the public-private partnerships, but there's also our partnerships with the overseas laboratories, in which we have in Thailand and in Kenya, Egypt and Peru. Some of them have been in existence for over 50 years. These partnerships are not just to provide us a platform for surveillance and for testing new products, but it's also a way of capacity building so that we can also pass on what we have learned and also learn from our partners. In most of these overseas laboratories, the majority of the people that are working there are local nationals. And there really is a trust relationship that is built up, some of the people having been associated with that partnership for over 50 years. And there are strengths and weaknesses that each of the partners bring. And the more we talk to each other, the more we interact with each other, the more we learn where we can make a real difference. I know that we execute quite a bit of PMI funds. We execute quite a bit of PEPFAR funds at some of our overseas laboratories. And it's not just the laboratories. Those laboratories actually are a jump-off point for work in other countries as well. And it's not just a logistic aspect like that, but it's also a scientific aspect. We've learned a tremendous amount from the work that's being done with the HIV vaccine, as well as the HIV vaccine, learning a tremendous amount from the work that is being done with malaria. So there's scientific interactions and partnerships that are done across diseases, and as well as all of the logistic work that I've just talked about.
Again, it sounds like this is a remarkable partnership, public-private advocacy. Is there anything that this institution, that we can do here as men and women in Congress to help continue to facilitate this partnership? Or is there anything, obviously the law of unintended consequences sometimes hinders partnership, and is there anything that you would want us to do outside of increasing research funding? So.
Yeah. The fact that you're calling for an update and having this hearing to support this U.S. government foreign assistance program is evident to our global partners and the countries that we're working with. There isn't an opportunity that goes by where I don't pay tribute to the leadership, the bipartisan support of this Congress. It is critical. We need the political leadership and we need the funding. And everybody understands the constraints that we're currently under. And so our pledge is that the funding that's appropriated to this program and our other health programs, we're going to do everything we can to be transparent, accountable, and deliver impact that'll convince the American people that their tax dollars are being wisely invested. When we show results, it's really kind of a no-brainer. They're going to say, I wish more money was going into programs like this. I hear it all the time.
Great, thank you. We'll bring some of that common sense approach here to Congress as well. I'll yield back to
Thank you very much. Vice Chairman, Mr. Weber.
Well, thank you, Mr. Chairman. A couple of questions for you. Of course, you guys started with men and women fighting men and women overseas. What is the instance of cases of malaria in our own armed forces? Is that up, down? Can you give me kind of a breakdown?
Well, sir, we still suffer from malaria, even though we have these interventions, principally because we do have troops that are going to be operating in areas in which they may not have expected to run into malaria, so they may not be on prophylaxis, or it may be in the fog of war, if you will, in which they don't have opportunities to protect themselves with the bed nets. We have done interventions, though, that may help drive the numbers down. As I said in my testimony, we have maybe 100 cases per year yet that are still bothering us in the military, and we'd sure like that to be down as close to zero as possible. So some of the things that we could do are to intervene where we don't necessarily have to have the soldier involvement in it. A vaccine would be absolutely wonderful. But in the meantime, we have situations in which, for example, the Army and the Marines, now all of our battle dress uniforms are permethrin treated from the factory. And that's a true improvement because now the individuals don't have to think about an intervention themselves. It's already there. Those types of efforts are going to help drive them down. It sure would be nice to have zero cases and not have to worry about malaria intervening like it did in 2003 in Liberia. But that's something we need to continually plan for and think about in the back of our minds.
Well, thank you for that. Colonel, I wasn't here during the testimony. It turns out I don't walk as fast as the chairman does. And so I apologize if it's redundant. Malaria was eliminated, pretty much eliminated in India, as I understand it, but now it's starting to come back. Speak to that, if you would. Why is that?
Yes, in India, in the 1960s, it was virtually eliminated from the entire subcontinent. Today, we still have, they've actually increased the number of cases, potentially up to 200,000 deaths per year. And it's fairly widespread. I've recently, over the last number of years, traveled in India to about 20 different cities, and from the rainforest all the way to the desert, so you can see patients lined up with malaria, and it's having a true impact. The reasons for that are pretty much the same reasons that we should remain vigilant and do remain vigilant here in the United States. We have a susceptible population. We have the vector present, the mosquito that can carry malaria, present throughout the entire United States, just like they did in India. And all it takes is the reintroduction of the infection into the population and into the mosquito population without an adequate response. We've been very fortunate that the CDC keeps very, very close eye on this and has prevented any small outbreaks from becoming big ones like it has in India. But we remain vulnerable as long as there's malaria anywhere in the world. Certainly, all it takes is somebody getting on a plane and 8–10 hours later to be on one of our borders and potentially bring the disease back home.
Okay, thank you, Mr. Chairman. I yield back.
Thank you very much. Mr. Meadows.
Thank you, Mr. Chairman, and thank you both. And Admiral, thank you so much for being so candid with regards to your fiscal oversight and understanding the demands of where we are today, but also knowing that as a wise steward of that money, I take you at your word, but also see it in your passion in your eyes that you're willing to invest that wisely. And I just wanted to say thank you, not on behalf of Congress, but on behalf of the American people for doing that. I want to go on a little bit further, and let's talk about the dangers to our men and women in service. Colonel, if you could speak to that, because really when it gets down to funding, most people are only concerned about providing funding if it affects them. And that's a sad commentary, but that's the truth of the matter. And so what I would like for you to do is help the folks back home understand, one, why do we need to be investing these dollars? What are the dangers to family members that may be serving overseas? And perhaps talk a little bit about the reintroduction into some of these areas that we felt like were malaria-free, that now we're seeing that it's come back because, as you say, we're in a global, transient world now. And so one disease in Vietnam, showing up in America is just a few hours away. And so if you could comment on that, please, Colonel.
Yes, sir. So the threat to our military, to our men and women that are serving in the uniform of our country, is very much dependent upon where they happen to be doing it, where they happen to be serving at the time. If they're in an area, say in Iraq, we found that there was very little malaria, if any at all. And we really didn't have much of a problem with malaria there. Certainly we do have a problem with it, though, in places like Afghanistan and in other areas in which we may be providing peacekeeping missions, for example, in Africa, in which there's a tremendous amount of transmission. As I've said, the disease, the parasite, is very smart. No matter what we produce, no matter what we come up with, be it an insecticide or a drug, it's going to figure out a way to work around this and act.
So what you're saying is it mutates and changes enough where it can go against the technology that we have.
Yes, sir. So we need to continually take a look at this. The reason it's important, though, and the reason we talk about global health is because for one reason is that as we work on these solutions for our soldiers, it's got a much broader impact, and it's got a much broader unintended consequence of being able to help other individuals that have malaria. But on the other hand, if we reduce the amount of malaria and other infectious disease threats worldwide, our soldiers serving in these areas are going to be at reduced risk as well. And also the issue of making sure that we invest in decreasing the destabilizing effects of these particular diseases so that maybe we don't have to have soldiers there in the first place because they're not unstable areas because of the fact that their health is better.
And so what you're saying is part of the unrest is not just economic, it is health generated. Is that what?
Well, health has an impact on the economy. If you're sick with malaria, you can't work. If you can't work, you can't provide for your family. And there's this vicious cycle that happens. While we may not think about health as the very first thing in an unstable country, health certainly has some impact in the background, and we just have to trace back to where that is. If you're able to work, I think most people want to work, no matter where they are in the world.
Right. Let's go back to this partnership that's been alluded to with both the pharmaceutical companies, with CDC, with NIH. Who takes the lead? how do we make sure that we're charging, in our military, we have rank, and so we know who we follow. In these partnerships, it becomes much more problematic to see who's taking the lead and who's making the decisions. What are some of the successes there, and perhaps, if you care to comment, what are some of the barriers to that?
Speaking from the PMI perspective, I appreciate the question a lot, but if you go back to the Lantos-Hyde bill, you'll see that there were specific authorities and responsibilities given to how the program was to be established and run and managed and report back to you.
And are we following that?
Yes, sir, we are. And I would venture to say that that's one of the key reasons for the successes and the progress that we're making. There is clear lines of authority and responsibility, and it also encourages and enables us to have an effective interagency, collaborative, functioning program. So I would commend a review of that simple governance concept as we ask the question about partnership.
So you're saying it's a success?
In my view, yes, sir.
So we need to repeat it throughout all other areas of Congress, is what you're saying?
I would say it's a good reference depending on what the outcome is desired, okay? But on the global level, it's much more difficult.
Right.
And there are collaborative bodies at WHO, partnerships, Stop TB, the Rollback Malaria Partnership. At the Rollback Malaria Partnership, which is meeting right now, and I'm skipping it because I'm here, the Gates Foundation, the UN Foundation, Malaria No More, multiple private sectors, the pharmaceuticals are there, the countries, the endemic countries, Asia, Latin America, and Africa are there, along with the major funders, the Global Fund, the UK, and the US government. We're looking at the global challenge, looking at the plan, and having discussions about how we work together on a global partnership to move towards control, elimination, and one day, eradication. So there are different mechanisms depending on where we are to enhance and to develop these partnerships. I would like to say that over the 6 years that I've been in this job, that program, those mechanisms have continued to mature and become more professional, and I spend my time by going to them because I think it's worth it, and we're able to influence and provide technical as well as programmatic leadership to achieve common ends.
And you would agree with that, Colonel?
I would. For the standpoint of being in military, of course, we do what we're told. I'd like to think we're very good at doing what we're told and making the best with what we have. So the partnerships have been very good.
Do I have time for just 2 more questions, Mr. Chairman? Wanted to follow up with that then. From a legislative standpoint, you outlined some of the things that were good. And I'm not asking you unless you have something on the forefront of your mind to speak to this, but I would love to see if there are anything legislatively, tweaks, reporting, accountability that we could provide to follow under the chairman's leadership to address by Congress. Is there anything that comes to mind? And if not, if you could have your staff work on that, report back to the committee.
Sir, I think that's a great question. I would like to come back to you with specifics depending on what you would find helpful as you look forward to fulfilling your responsibilities. But I think it's worth time to continue to look at that, and we'll get back to you, sir.
And then my last question, it really gets back to, I think we're in clinical trials, in the 3rd clinical trials in terms of a vaccine. And having seen that, that's a hopeful sign if we're getting to stage 3 clinical trials. My question is how do we look at the severity? Because I think you mentioned in your testimony the severity of those that are 5 months to 17-month-old. How do we measure quantifiably the success of that. I mean, it's very difficult when we have children to figure out, if pain is on a scale of 1 to 10, because they won't rate it out. How are we doing that?
One of the ways of assessing severity when it comes to malaria is actually pretty simple, because severe malaria is a disease, although we have very uniform and very stringent criteria that we need to follow. I think it's real simple. If you can't take water, if you can't swallow things, if you can't take a pill to treat the malaria, and you need an IV treatment, that's pretty severe malaria. And the outcome measure is unfortunately very easy to measure, and that's death. Because once they start down that circle of having severe malaria, it takes some extraordinary measures.
So primarily through dehydration, or?
There are a number of different mechanisms, sometimes through pulmonary malaria, sometimes through cerebral malaria. There are a variety of different ways, but typically with children, it's because of anemia.
All right. I think the Chair's indulgence, I would also ask if you could, for the record, address if there's any nanotechnologies that we're using in terms of clothing, netting, or so forth that might be out there, or at least hopes in terms of future research in terms of nanotechnology. And with that, I yield back, Mr. Chairman. I thank you.
Thank you very much, Ms. Meadows. And Mr. Stockman?
Thank you. I don't know who could answer this question, but I think I was watching Frontline or one of those shows, and they talked about the Chinese counterfeiting malaria medication and how that impacts and creates resistance to malaria. And that's kind of a big elephant in the room. I mean, as we're spending millions, in some cases hundreds of millions of dollars developing a new drug, they're out there emulating and making fake copies of it. And as you take the pill and you stop taking it, of course, that's how the resistance builds. I guess I'm asking, has any of that, have you guys addressed that issue on how to stop the counterfeit?
Sir, it's a global issue that has a lot of visibility and attention. I know it's a priority for the State Department right now. It's a matter that we are very concerned about, because people that are sick with malaria taking counterfeit, fake, or unsafe drugs are going to continue to get sick and die. So it's not only a health issue, but it does feed resistance, and it really is a concern to us in terms of how it manifests itself in the resistance of the parasite. But on the criminal side, it is a high priority, and we're working with our governments and criminal agencies to take appropriate action, but we've got to stay at it at multiple levels: diplomatic, technical, and at the country level, where these drugs are being regulated or not regulated, purchased and distributed. Okay.
There are actually two issues with that particular question, sir. One of them has to do with actually counterfeit ones, in which they're trying to sell them for the for other manufactured ones so that they look the same. Typically, they don't just put sugar pills in. Typically, what they do is they add just enough of the drug there, so if somebody were to test it, they would detect the level of drug
That's even worse, too, because
that's even worse, because what it does is it feeds into providing a low-level exposure of that drug to the parasite, so it kind of helps them learn how to become resistant. So that's a problem. But there's also a problem of poor quality drugs. And one of the hallmarks and one of the reasons why people love the U.S. medical machine, if you will, is because of the fact that we have good quality products that are available, manufactured under good manufacturing practices and tested under good clinical practices. And quite often we compete with other countries that may produce a drug under different standards. They can sell it for a cheaper amount, and therefore it becomes used. So quite often what happens is that we need to make sure that we look at, for example, the technical ways and the legislative ways and the diplomatic ways of making sure that we're using not just good quality drugs, and that everybody is kind of following the same standards when it comes to that, but also trying to make sure that we ferret out and get rid of these counterfeit drugs.
The implication in the program is that it's a staggering amount of fake drugs out there. Do you have any way of quantifying how much is fake and how much, I mean, do you guys ever sample it? Because they showed a package and you couldn't tell the difference. It was stunning, and it looked like an American-produced product. But they were implying that there was a lot of it out there. Is that quantifiable? You guys trace that?
This is being, we aren't ourselves particularly following that, but there are a number of different organizations that take this on and really do a wonderful job of finding out exactly how much is out there. It's worthwhile for them because instead of the $60 that they could reap for it, they may only cost them pennies to make it. So they get quite a bit of profit as opposed
But do you know
to ours.
do you know who those folks are, so we can have them before our committee? Because if this, I feel like what we're doing is we're competing against ourselves. We're throwing millions of dollars, which we want to do because we want to save lives. But at the same time, if somebody's in the boat drilling holes, it'd be nice to stop that person from drilling holes. So if you have some experts, if you can get with the chairman, let us know. I'd love to hear their testimony on exactly how big this problem is, because if we constantly are competing against ourselves, trying to produce new stuff, and then they emulate it, and then, like you said, the Oregon gets a little bit of it and just again, then we'll be in a never-ending, we're chasing our tail. But do you know the individuals that would have that information?
I don't have that information right in front of me at this moment, but I do know that there are several organizations that are following that quite closely, and there are congresses that meet, international congresses, because this is an international problem. It's not just here in the United States. And they follow this very closely. They try and track down where these are, but finding the actual individuals or the actual country that's producing it has proven quite elusive.
We do have some information, but I think what I'd like to do is go back, look at our files, and then get back to you specifically to make sure we can answer the questions that you have and share what we have. Okay?
I try to remember. I think the show was Malaria or something. It was really fascinating. Or I can't remember. The other question I have, if I may, we eliminated malaria here, and a lot of us see the film clips of it, how we eliminated it, and no one ever wants to talk about it. But it was very effective. It's how it was eliminated in India and a lot of places around the world. And now with atomizing our DDT, you can not have the impact on the environment that we had in the 50s. And I remember you see the film clips of kids just covered with DDT, and my brother was one of them, and he turned out, I think, fairly normal. He might disagree politically at times, but he's okay. And then I see the sacrifice. I know we have to trade off a balance, but your heart goes out to these young kids who don't have the same protection we had. And I wonder if there's really a trade-off where we should maybe, because of technology now, reintroduce that product, because it could save, some estimates, millions of lives. And I would like to see it reintroduced under the controlled situations where we can make the molecules much smaller through atomizing the product.
Sir, there are 12 approved insecticides on the WHO approved list. DDT is on the list, and we were using DDT in 3 of our programs. We switched off of DDT because there was a resistance developing by the mosquitoes. So we alternated to a pyrethroid or another effective insecticide. So the issue of DDT is front and center, but I think what we need to do is continue to focus in on effective, safe insecticides that are approved, and then look at the best application based on resistance, protocol, and the data that we have.
I also noticed they're taking, and I'll indulge me a little bit and I'll release back time, but aren't they taking mosquitoes and injecting them with, so they don't bear other mosquitoes and things like that, which I guess birth control for mosquitoes, which is kind of amazing. RU-48, 6 for mosquitoes.
We do have a number of very innovative strategies that are being developed by our entomologists that look at doing things besides insecticides, because we do know that just like the parasite is going to be able to develop resistance to our drugs, the insects develop resistance to our pesticides, and eventually will overcome the ones that we have available to them. So we need to be thinking, as it's been said, outside the box into other strategies, which include sterilized mosquitoes that are able to decrease the burden of the vectors that are present.
And lastly, my father used to do this. He was a zoologist, and what he used, I don't know if you can do this, but he used vegetable oil on steel ponds because the larvae comes up to get air and then gets vegetable oil. Is that something that you can use widely, or?
Larviciding is an option.
You're being diplomatic.
Yes, sir. But it's an important one.
You can say, here, I'll switch.
Because where we work, the application of larviciding by WHO guidelines isn't the most effective, costly, effective program.
I know they did in Panama too, right?
Yes, sir.
Yeah.
So there are certain parameters that WHO says ought to be used if larviciding is considered an option. In the countries where we're working, we're not even looking at it because of the places and the conditions would not make it a cost-effective intervention for prevention purposes.
Well, thank you for your candor and your time, and you guys have been great. Thank you so much.
Thank you very much, Mr. Stockman. Not to make light, but when Mr. Stockman was talking about the foggers, I grew up in Island, New Jersey. My friends and I, when we were 8, without our parents' knowledge or consent, used to follow the fogger, on our bikes. We were covered with the stuff.
Me too, Mr. Chairman. That's our problem.
That's when I decided to run for Congress. Thank you so much for your great witness today, your testimony, and above all, your leadership. It is so greatly appreciated. I do have a number of additional questions, but in the interest of time, we'll convey them to you in written form, including the impact, if any, that sequestration is having on our efforts to combat malaria. So thank you so much. Just pursuant to the rules of the committee, we will now have to end the formal part of the hearing and go officially to a briefing. It is part of the rules of the House and the committee, I should say, to receive testimony from Ambassador Mark Dybul. So thank you. So I will welcome the ambassador to the witness table. Ambassador Mark Dybul, and it is a very high honor to welcome him here today, is the executive director of the Global Fund to fight HIV/AIDS, tuberculosis, and malaria. As an immunologist and as an administrator, as a teacher, and as a leader, Ambassador Dybul has worked for more than 25 years to help prevent and treat infectious diseases. Ambassador Dybul has written extensively in scientific and public policy literature. He is a founding architect and a driving force in the formation of the President's Emergency Plan for AIDS Relief, or PEPFAR. I know, and I'd say this firsthand because I was very involved with that legislation. It was Congressman Henry Hyde who was the prime sponsor. It was a bipartisan bill, but Ambassador Dybul was absolutely critical in crafting that text, the language, the all-important law, and its reauthorization in 2008. So I want to thank him for that leadership. He was formally appointed as U.S. Global AIDS Coordinator and with the rank of Ambassador from 2006 to 2009. Before joining the Global Fund, he was co-director of the O'Neill Institute Global Health Law Program at Georgetown University, where he was also a distinguished scholar. And without objection, his full resume will be made a part of the record. Welcome, Ambassador Dybul.
Thank you, Mr. Chairman. It's a great privilege to be back before this committee in a different role. Other members of the committee, thank you for your dedication and to being here. And this committee, and I know from firsthand, has had such a long, strong bipartisan support for serving those in need. And Mr. Chairman, thank you for your leadership going back so long in this fight. And I know now you have new friends and colleagues that will help support this effort with you. You've heard a lot of data and the information, and so if acceptable, I'd like to enter my testimony for the record and highlight a couple of key points, including in response to some of the issues that have been raised. This is a very difficult financial time. We're very conscious of that. And coming before this body or any body actually around the world to ask for increased resources for foreign investment, we understand is a difficult ask. And I think it's important to understand why we are doing this now. It's easy to say in these difficult financial times, can we wait 3 or 4 years, 5 years, until we have better economic times and better budgets? The reality is that because of the massive investment of the last 10 years, and because of advances in science and our understanding of the diseases, we are at a critical tipping point in the history of malaria and HIV and tuberculosis. We now have the science and implementation understanding to actually end these diseases as public health threats and to put us in a position to ultimately eliminate them. We have never had this moment in history before. Malaria has been with us as long as history has been recorded, as long as we know. We are the generation, you are the leaders that can actually put us on the course to end this disease as a public health threat. And that's why it's so important to act today. And I'll expand a little bit on that. The scientific advance you've heard about, new long-lasting insecticide-treated nets, new indoor residual sprays, new treatments, much more effective combination treatments, and eventually a vaccine, which I'll come back to. One thing we've not talked about is the success of the interventions to date, leading to a new understanding and epidemiology of the disease. We have had so much success over the last 10 years, which you've heard about, that high transmission areas are becoming much more confined. Good example is South Africa and Swaziland. They now have malaria only on their border with Mozambique. Not too long ago, they had malaria throughout their countries. We see this over and over again because of the success of the interventions. We now have areas that are being more and more contained with high transmission, which allows us to target our interventions much more effectively. We're also understanding that high levels of the parasite in the body are very limited in geographic scope. So we are now focusing our efforts on those areas. All of this has been made possible because of the experience of the last 10 years, because of the investments that have been made. We are now in a position to actually get for you a full return on that investment by completely controlling and ultimately eliminating. If we succeed in what I just described, a partially effective vaccine would be enough in all likelihood. And that means some of the things the Colonel talked about could be in our lifetime available because if we control the infection to such low rates, to such inefficient transmission, then you don't need an overly powerful vaccine. And that's the opportunity before us. But we are at a tipping point, and tipping points can go in 2 directions. You can continue on the course you're on, or you can tip backwards, and you've already talked about some of that tipping backwards that has occurred. We have extraordinary data for how quickly, especially in malaria, you can tip backwards from success. Zambia is an excellent example that achieved fantastic coverage of interventions, significant declines in their infection rates, but because of funding issues, were unable to replace nets and immediately saw an uptick in new infections. We've seen the same thing in Rwanda and other places. And while you've talked a little bit about what happens when the malaria comes back, one thing that is important to emphasize is if you protected a child for a few years, and then they no longer have protection, it's almost worse than never having protected the child because they were never exposed to malaria. They have no immunity to the malaria. So if they then become infected, their malaria will be far worse, and as the Colonel described, can lead to the meningeal, pulmonary, and other fatal forms of the malaria because they were protected and became unprotected. And that's why the data the chairman mentioned on the inability to just replace nets is so striking and such a important moral issue for us. And that's why the Global Fund dedicated $450 million this year to reduce that gap from 77 million to 24 million bed nets, but we still have some gap. And that's just to maintain, not to achieve the vision we talked about to drive towards complete control. The bottom line of this is not a bottomless pit. This is not what we would have done for the last thousands of years in the fight against malaria. We are actually on a tipping point where Today, we can say we can completely control and ultimately end malaria in the world. But it's going to take resources. And in that regard, we're very grateful to Congress for the 2013 budget. We know how difficult that was to maintain the financing for the Global Fund. That allowed us to replace all of those bed nets that otherwise we could not have replaced. We're very hopeful that the 2014 budget can meet the President's request, which is similar to the 2013 budget. In fact, it's the same. And one thing I believe is important for you all to know is that your contributions to the Global Fund are leveraged 2 to 1 from other donors, because you can never give more than 33%. And we use that to leverage 2 to 1. So every dollar you give gets us $3 in the fight against malaria. As has been mentioned, the Global Fund's committed about 1/3 of its $23 billion portfolio to malaria. We work very closely with the President's Malaria Initiative. We support the same comprehensive approach. And more recently, we reorganized our structures so that we are focused on the high-impact, high-disease-burden countries in a much more aggressive way, the countries that you all have mentioned where most of the malaria resides. Partnership has come up a fair amount, and I'd like to just say a few words about the close working relationship with PMI and others. One of the areas we're working aggressively in to ensure that when you go to the taxpayers, you can tell them the money's being used well, is to increase efficiencies. Last week, the Global Fund hosted with PMI and UNICEF a new round of negotiations on price of bed nets to drive the prices of the nets down by using our collective buying power. First time that's been done that we work together to use our collective buying power to drive those prices down. A second example is to partner with the private sector and the U.S. government through USAID. Yesterday, we announced a new innovative process that will allow us to more rapidly utilize the resources that you make available to us and to leverage the private sector's capability of guaranteeing resources to do that. A third example, and one that has come up, is work with PMI and other global partners in the Mekong Valley to address drug-resistant malaria. The Global Fund's committed $100 million to a regional program there and has partnered very closely with PMI and the technical expertise of the U.S. government and other partners to ensure that our global investments are not threatened by the resistance that's developing there. A fourth example is to partner with national malaria control programs to move towards that use of the science, use of the epidemiology to make sure the resources you commit are the most effective in dedicating where the highest risk transmission is. A final example I will give you relates to counterfeit drugs. Mr. Stockman, you asked who was working on this. Actually, the Food and Drug Administration is working very aggressively on this, and there are several other international partners, including the private sector, that's developing new technology so that we can identify counterfeit products in a very rapid way through international consortia, and the Global Fund is actively involved in those efforts, which is something that a multilateral can do. It's more difficult for bilaterals to engage in. I also want to point out that we're not just relying on you and your taxpayers for what we're talking about. Africa itself is stepping up in a dramatically new and exciting ways, as is India and parts of Southeast Asia. The Africa Leaders Malaria Alliance brings together the heads of state of Africa at that level to focus on malaria. And in part as a result of that, last year alone and annually, $625 million comes from countries themselves to fight malaria. So they are partnering with you with their own resources as well as their commitment. A good example is Zambia, which in the last 2 years has almost tripled the resources they commit to malaria. The private sector is also in the game heavily, in part because of with the commodities they provide, in part because of the delivery systems, but also with money. Chevron has provided the Global Fund about $55 million. Product Red is a partnership of CEOs and companies in the United States that provided the Global Fund over $200 million. The Bill and Melinda Gates Foundation has provided significant resources, and we are also targeting other high net worth individuals. So we're not looking to you all alone. We are developing financing partnerships that will relieve the burden on the American taxpayer in an exciting way. And one of the reasons heads of state in the private sector are so involved is because something what was touched on but not probed enough perhaps, and that is the impact of malaria on productivity. Nigeria alone estimates that they lose over $3 billion a year in lost productivity because of malaria. Globally, the estimates range as high as $40 billion, and most people think those are significantly underestimated. And that's why the private sector has gotten engaged, because Chevron, for example, in Nigeria, was losing so much time in their offices and in their production facilities because of malaria. And so it was good business to intervene. And that's good for the United States to have a rapidly growing economy in Africa, to be a buyer of our goods and services. So the opportunity before us is huge. The partnership that is responding is huge. But the most important opportunity is, in fact, for the first time, which we could not have told you 2 years ago, we are on the cusp of completely controlling this infection and ultimately eliminating it. As has been mentioned, we had malaria in this country. 8 United States presidents have suffered from malaria, including Teddy Roosevelt and John F. Kennedy. John F. Kennedy, of course, was after 1951 when we eliminated it, but he served in Vietnam and came back with malaria. And as we talked about, that is a threat that is growing for us. CDC, in fact, was created initially largely to respond to malaria and is still deeply involved. We've now eliminated in our country, or in the United States, but there's a risk it could come back, and we have the opportunity, if we invest wisely, if we use taxpayer dollars well, if we continue this partnership, to achieve something that has not been possible for thousands of years and is possible today, to completely control this infection, ultimately to have more scientific advance and move towards elimination. And if we don't do that, the cost in millions of lives is extraordinary, but more, the billions upon billions upon billions of dollars that you will continue to have to dedicate would not be necessary if we act today, if we act now. So we can leave for the first time a generation free of malaria that has not been around since recorded time in history. What an opportunity. What an opportunity. If we maintain our resolve, if we work together, if we capitalize on new scientific advances, collectively, we can accomplish one of the greatest feats in history, to defeat a plague that has been with us for thousands of years. Now is the time to act. Now is the time to invest so that we don't pay forever. Thank you very much for your attention. I look forward to answering your questions.
Ambassador Dybel, thank you very much for your testimony and for your leadership. Let me just, your testimony is quite extensive, and I do hope that all members of the committee and the full committee as well will read it, because you really lay out even more than what you have just done very well in your oral presentation. You point out that we can all agree that no child should die for lack of a $1 insecticide-treated net, and I think that very low cost is underappreciated. People don't realize how cheap it really is. A $1 rapid diagnostic test kit, and a $7 drug treatment regimen if, of course, the child is sick with malaria. Could you, you talked about in your testimony about the $3.5 billion gap, and I'm wondering, in addition to the United States, and I frankly think we should do more, and I know maintaining current levels with the crisis and the budget that we face is job one, but certainly if we could go above that, obviously that is all value added. Who are some of the other countries, what other countries are really stepping up to the plate? And you pointed out in your testimony that some of the affected countries like Zambia are doing more, which is greatly appreciated because they have resources and they're prioritizing those resources. But what other countries, particularly in Europe and elsewhere, are really stepping up to the plate?
Thank you, Mr. Chairman. And I think it's a very good question, because it really does emphasize that the U.S. isn't going it alone. The U.S. leadership has been out in front since the beginning of this fight on malaria, but it has not had to go alone. So the Global Fund, as I mentioned, is a multilateral institution. We are not part of the United Nations, actually. We are an independent multilateral, and we were created that way so that we would have more flexibility. And through that mechanism, we have a board which has the major contributors and countries represented on it. The United States is by far the largest single contributor to the Global Fund, but as I mentioned, you can never give more than 33%, and that leverages 2-to-1 from others. The other countries that are large contributors, France is the second largest contributor to the Global Fund. The United Kingdom is the third. The United Kingdom also has a large bilateral program with a big emphasis on malaria, so they also have bilateral efforts in addition to their contributions to the Global Fund. Japan, Germany, pretty much all of the Nordic countries had participated to very high degrees. We even have countries like Russia contributing to the Global Fund. India provides a contribution. Thailand provides a contribution. So it really is a way to have a shared responsibility, a global response to these epidemics. But importantly, as you pointed out, African countries themselves. South Africa not only receives grants from us, they actually provide a gift to the Global Fund. Zambia is considering such a gift. Namibia provides a gift to the Global Fund. So at the same time, they are moving to fund their own domestic programs. They're trying to contribute to the broader effort globally. So it really is a shared responsibility. I would also like to mention again the private sector contributions, which are critically important. The Gates Foundation, Chevron, Product Red. So you are in there as a leader, but you don't have to go it alone. And we work very hard to ensure that your money is matched 2 to 1.
Let me just ask you on the insecticide-treated bed nets. You suggest that 77 million nets are needed just to get back where we were in terms of, especially because some of the nets wear out after a 2 or 3 year useful life. The WHO says that to have complete coverage, we need 150 million such nets. Where are we in terms of actually getting to those numbers? And secondly, had President Bush not created the President's Malaria Initiative, or the PMI, where would we have been?
So in terms of where we are, what is needed to get to that complete control we talked about, that's where the $3.4 billion gap comes from. If we are really going to contain the epidemic, if we're really going to get to that full control so that we can, with a partially effective vaccine, eliminate, but at least eliminate as a public health threat, we have the knowledge today, that's what that $3.4 billion would do. The 150 million nets a year is really to maintain, and we're not quite at universal coverage yet. We have a little bit to go. And then we also need indoor residual spraying. We also need to treat people who do get malaria, which actually contributes as a preventive tool as well because you reduce the parasitemia. And that's where the $3.4 billion would fill and allow us to contain. Again, I know that sounds like a lot of money, and it is a lot of money, but the opportunity cost not to invest today is to actually lose the return on investment of what you've invested for the last 10 years because, again, we're at that tipping point, and we can either continue to go down and get to complete control, or we can slide back down, in effect, losing some of the return on investment. Obviously not all of it, since we've saved millions of lives. President Bush's leadership was extraordinarily important. The President's Malaria Initiative has had a significant impact, and really with the Global Fund and the UK's program are the major funders, external funders, along with the increasing domestic contribution in the fight against malaria. But again, everyone's getting in the game, but it takes leadership to cause that effort. Prime Minister Blair was actually a tremendous leader and worked closely with President Bush at Gleneagles, and the UK will be hosting the follow-on to the Gleneagles G8 Summit this year, and we are hopeful that they will recognize the importance of this partnership through the G8 going back to that Gleneagles when President Bush and Prime Minister Blair were in office that have led to where we are today with success in malaria.
Thank you. I do have other questions, but in the interest of time, I'll yield to my good friend and colleague, Mr. Weber.
Thank you, Mr. Chairman. Mr. Dybel, you said that Swaziland and Mozambique had almost eliminated malaria, only had it in some areas on their border with Mozambique, I think. How did they do that?
And South Africa is the same. And they did it through a strong national program with external financing and all the partners working together with a common objective to get to complete control. And so they, with long-acting insecticide-treated bed nets, with available treatment, with the correct treatment, the effective treatment, they were able to push it out so that it is really because of the border. Mosquitoes don't much follow geographic borders. They go wherever they want to go. And so it's a very important issue because we're seeing this happen in country after country where they are actually managing the infection in their own countries, but it's the bordering regions. So we're shifting to an approach that looks at cross-border transmission and cross-border control so that we can do that. But it really was through what we've been talking about and you've been talking about all day, using the science, using the advances and interventions, getting the ground game so that you get the coverage rates, using faith and community-based organizations to make sure people are sleeping under the nets and that people are accessing services, and having a national strategy and a national approach. It's not just these two countries. We've seen it right now. Tanzania has had a 50% reduction They have 90% coverage of their bed nets. They've had a 50% reduction in mortality and case detection, and an almost 45% reduction in all-cause child mortality because malaria contributes so much. So many countries are pursuing this effort, and what we know now is if we act in this coherent way, if we use all the interventions smartly, we can actually get to complete control.
Let me ask you, are you able to quantify, when you look at that country, are you able to say the program cost X, they poured X amount of resources into it, and their incidence went down? Is that quantifiable?
It is. It is. In fact, we have those data for you. We have the total dollar amount, and we have the total impact. What we're doing now is actually combining all the spigots of funding. So what we've done in the past is look at what the Global Fund invested, look at what PMI invested, look at what the country invested. What we're now doing is taking a country look and saying, what should that cost be to actually achieve those results? And again, working with the U.S. government to get the cost of the nets down, getting the cost of the supply down. So I think what you're getting at is exactly right. We now have the knowledge to use how much it should cost and to drive the cost down even further.
All right, and then final question, Mr. Chairman. My colleague, Mr. Stockman, had asked the previous panel, could they give us the names of witnesses who knew who was doing the counterfeiting? And let me just say, tongue-in-cheek, we don't necessarily need those names. We need the names and the addresses of the counterfeiters, so we can send Igor and Bruno over there with a number 34 baseball bat and break their kneecaps. Are there such a thing as sanctions, or when you identify a country that has that kind of counterfeiting going on, is there a database that says this country has been participating, and is there such a thing as, how do you sanction them?
It's rarely a country, it's usually people working within a country. So, and it's often
But if you were able to get with that
Yeah.
government and say, y'all need to shut this down.
Which is exactly where it's going. And Interpol is actually actively involved in global counterfeiting with the FDA and others exactly for that purpose, so that people can begin to identify where people are basically have refuge to do counterfeit activities, track them with new technology, and then work collectively as an international community to shut them down.
And so Interpol takes the information. There is a particular provider of medicine that's sending counterfeit drugs in, and they can track that back, and they're keeping a database who not to buy from, for example.
It is being developed. These programs are being developed because everyone's taking so much attention for it. To Mr. Stockman's question, I think if you brought FDA in, they could give you a very full picture because they are very aggressively and actively involved in all of these conversations and using these new handheld technologies where we can identify counterfeit and trace it back.
Okay. Thank you, Mr. Chairman.
Thank you. Mr. Meadows?
Thank you, Mr. Chairman. Thank you for your testimony and briefing. And wanted to follow up a little bit in terms of, you mentioned the Global Fund, and I think you implemented a series of reforms, due in part to a response from Congress. And as you've implemented those reforms, how would you say those have progressed since your leadership, and what's still left to be done?
Thank you for the question, because I think it's very important and really is a testament in my mind, and the reason I was so interested in going to the Global Fund is it's a true learning organization. It really looks at itself constantly to say, how can we improve, how can we do better, and let's change. And as we all know, that is not a typical approach in organizations. Right. And that's one of the most exciting things about it. So the reforms is really an evolution from looking to see where we are today, what the landscape looks like, and how do we implement more effectively with higher impact. So some of the key things that have been done, and again, the board, the U.S. being an important member of the board and the U.S. Congress pushing, really the board itself pushed for these reforms. And how rare is that you have a governing body pushing for this type of change? Not because often we think change means you made a mistake. Sometimes change is good because you're learning. One of a few things we learned was that we didn't have as much focus on high-impact grant management as we needed to. And so we shifted so that now 75% of our staff is dedicated as a financing facility, which is what we are, to grant management, because that's our core business. and we're identifying into what our core competencies are and partnering more with other organizations, which is what we were created to do for technical and other purposes.
And so if you're looking at that grant management, what matrix do we use in terms of, one, the awarding of the grant, and then I guess the second part of that is the effectiveness once the grant has been given? What's the matrix that you're using?
So the matrix for how grants are given are based on disease burden, because that's where the impact's going to be. Co-investment, it's a key part of our how we make
So the better the
decisions now.
co-investment, the more likely they are to get the grant.
And also a requirement for co-investment based on your economic situation. So even if you have a high disease burden, but have a good economy, you need to be giving more, and we work on that in a formalized way as part of the grant-making identification.
And there's no other political agendas or sidebars that are evaluated?
No. The other is ability to implement in terms of rapidity. We don't want to dedicate money and put it in a country when they don't have the capacity to move it. And then we have a risk management tool, which is new, which looks at not risks of misuse of funds so that we can ensure that and go after any misuse of funds, but also risk and non-implementation, which gets to capacity a little bit. And what are those risks to implementation? Is it the supply chain? Is it human resources? Is it the inability to reach certain parts of a country for various reasons? And then we dedicate our resources to alleviating those risks. So it's a very complex matrix across those areas, but it's leading to a much more impactful approach.
So you're saying this is really more of a new funding model than you've had in the past, is that correct?
In fact, we call it a new funding model.
All right, so, thus my question. And so as we look at this new funding model, what can we do in terms of the planning stages and the implementation stages? Similar question that I asked the Admiral. What can we do from a legislative standpoint, knowing that we're only part of the pie, to help facilitate that and help encourage that to make sure that American taxpayers are getting what they pay for?
Yeah. Well, I'm probably a little biased since, as the chairman pointed out, I actually was involved in the writing of the legislation, but I think it's pretty good.
What tweaks would you make to your own writing? How about that?
I actually believe currently that the language you have is very useful to us, and it actually helped the fund, along with other people on the board, move towards this new exciting approach. What we are really focused on is the partnership piece, and that is in the legislation, that we should be focused on using the resources from the U.S. taxpayer from whatever source they come in the most effective way to have the greatest impact and partner and leverage. And that leveraging piece is something we have not always done well, none of us, and that's what we're seeing that's so exciting is in this new funding model, we actually bring all the partners together to ensure, and look at the epidemiology, look at the science, to ensure that the investments going in aren't duplicative, aren't ineffective, and are going to the right outcome. And then, importantly to the other part of your question, we evaluate it on a quarterly basis. How is the progress against the targets? And we can track it in a programmatic way so that we can adjust and reprogram as needed as we're identifying new realities on the ground. And grant management is not writing a grant. Grant management, you start grant management when you write a grant. You then work to ensure that the money is used well. We also only disperse funds as the countries need them. We don't give them a pot of money and then 5 years later come back and ask them what they did.
What a novel concept. Well, and so let me go back. You mentioned tipping point in your testimony here today. You mentioned tipping point 4 different times. And so as we see that, you said we're at a tipping point. We're at a tipping point, and we can go forwards or backwards. And yet what you also said is that we're at a position where we can eradicate malaria. What's the time frame, and what's the greatest barrier to? And I know that we're talking about science here. Yeah. We're talking about but probability. The probability of eradicating malaria within what period of time?
There are different models that have been, and I have to say a lot of this is mathematical modeling to predict when we intervene, how we'll do. The models so far over the last 10 years have held up pretty well, and really eradication will require a vaccine in all likelihood. What we can do is eliminate it as a public health threat and completely control malaria. And what we've seen in the last 5 years, I think, makes us much more hopeful that the timeline could be even more compressed. But we are actually, and the World Health Organization reports on this, about 20 countries have eliminated malaria in the last 10 years. And so you go from endemic or epidemic to control to elimination and then ultimately eradication. And if you look at the trajectory and the curves, we were seeing a 20-year horizon, 30-year horizon, but we're bending those curves down, including in countries, because of the success of the last 10 years. We're working on that precise type of modeling based on the new data to try and give us a better sense of that. But the wild card in that, and this is why I emphasize it a little bit, is what we're learning more and more is you can actually push the epidemic into corners. And that then means you throw everything you can at those corners to have the biggest impact to get everything down to low level. And if you can do that, then relatively inefficient vaccines should be enough. If you allow a couple of pockets somewhere, you're going to need a really highly effective vaccine. So a lot of it's going to depend on that variability. The one thing we do know is if we don't get down to complete control, near elimination, we will be continuing to fight this fight forever. And that's the tipping point. And that's the change that we've seen. Up until the last 2 years ago, we would have just had to keep doing the same thing, the same thing, the same thing until we had a vaccine or until all countries had enough economic growth that they didn't have some of the issues around pooling of water and other things. But now we're seeing the opportunity to push the timeline forward strongly. The reverse of that is if we don't stick in this game, we know what's going to happen. In malaria, more than any other disease, we know it will come back. And then we won't have the science or the tools to bring it back down. And the partially effective vaccine won't do it. And then we're going to have to just keep putting more and more and more money rather than investing now. And that's the issue of the tipping point. Again, under most circumstances, I've been around governments a long time, I've been around budgets a long time. I wouldn't come to you with a straight face to say, we need more money today, given the current economic environment, except for this unique moment in history. It's a shame it's coming at a time of tough budgets, but it really is, we have never had it in the thousands and thousands of years that we've had malaria.
Well, I must admit, it was very unique testimony, and thus why I followed up with a question. But with that, being sensitive to the other members, I want to yield back to the chairman at this point.
Thank you, Ms. Meadows. Mr. Stockman.
Mr. Meadows, you can keep going. Those are great questions. Enjoyed them. I'm following up on his line of comments and statements. You mentioned in your testimony, Mr. Ambassador, that Zambia and Rwanda are reinfected. Can you tell me, in your mind, because you've been working with this for so long, what is the rationale behind that? What happened?
So in both, neither country had eliminated, but they'd had significant control, very close to complete control in many areas. And that was because, like in Swaziland, they had national bed net campaigns, they had excellent care and treatment programs, they had an excellent program and a strategy that they implemented. But then they had some funding shortfalls, and they weren't able to replace some nets, or couldn't complete some campaigns.
Can I interrupt for a second? Was it the NGOs that had the shortfalls or the government?
Both. So in both cases, NGOs and the government are involved. Basically, it's one pot of money that gets divided out. Most bed nets are distributed through national campaigns that are organized by the government, because it's the only way you can do a national program, but implemented often through NGOs, especially the sleep under the net campaigns. And one important thing is you can't just distribute the nets, you need to make sure people know how to use them.
I was going to say, because don't they sell them, resell them, or sell them?
You know, sometimes that happens. With the national campaigns, that's rare because there's no reason to, because your neighbor has one too. So in the past, that actually did happen.
But I saw them using them for everything.
Yeah. Yeah, and actually there was a big education campaign. I mean, in the early going, people were afraid to use them, didn't know how to use them. Actually, in one case, I went into a home and I asked them where their bed net was because it wasn't hanging, and they pulled it out from under the bed in the plastic package because they thought it was so beautiful and still in the plastic package. So you need to go in and teach people and encourage them, and that's where the communities are so important, and the faith-based communities and the community-based organizations. In Nigeria, the Muslim community and the Christian community are working together to ensure that everyone in their congregation sleeps under their nets. It's part of their Sunday sermons. They do it all the time. And so that's really important. The funding shortfall was actually from external resources that the governments couldn't make up, and so they couldn't meet their deadlines to ensure that nets were replaced or the campaigns were completed. And then we saw the increase. But then we all came back in. We moved heaven and earth to get the nets in, and they came right back down. So it tells you how rapidly with this disease, if you lose just a little bit, you lose a lot. But if you stay contained and you stay suppressed, then you start pushing to where you just have these little pockets of high rates of infection.
Why do you think in Vietnam they have they're drug resistant? What's the rationale behind that?
So and it's more than Vietnam, it's actually the whole Mekong Valley. So Myanmar, Vietnam, Thailand, and it's really in that nexus, again, because the mosquitoes and the resistance doesn't respect borders. The resistance develops either because, as you pointed out, people get partially effective drugs, or they stop and start and don't take enough. And one of the key issues which has been raised is that, if you're out in a village and you're in malaria season and your kid gets a fever, you're not going to walk the two days or the day, and the clinic may not even be open. You're going to go to a kiosk, and you're going to pay for an anti-malarial drug. And the Global Fund actually has been engaged in a program to reduce the costs of the effective products in those kiosks to the level of what people do. They buy the cheapest product, which often is quinine or quinine-based products that in an area that has quinine resistance or quinolone resistance, and it just expands. Or they buy, rather than a combination artemisinin product, they buy a single artemisinin product, and we know it has to be in combination. And so these use of single artemisinin products rather than the combination develops resistance to the artemisinin. So we're trying to get the people in the private sector where people go to those kiosks so that when they go, rather than buying, they will still buy the cheapest drug, but it'll be the effective drug. And then sometimes they just don't complete the course. What we are working on internationally is bringing all partners together to really intensively address this resistance problem in this area, so that it doesn't spread, threatening all our investments everywhere else. But there are multiple reasons, and we don't necessarily, we're hypothesizing because we weren't there as it developed, but we have a pretty good sense of how it developed and what's necessary to contain it.
Thank you. I know we're getting ready to vote, so I'll yield back the balance of what time we don't have.
Thank you, Mr. Stockman. Just a few final questions, and maybe my colleagues might have a question or two before we go to votes over on the House floor. Just to, in 2000, I actually authored legislation that became known as the Combating Autism Act. It took 3 years to get the bill passed. And one of the cores of that piece of legislation, matter of fact, I did the reauthorization in 2011 as well, was surveillance. At the time, we thought that the prevalence of autism in the U.S. was 3 out of 10,000, at least that was what we thought in the early 1980s. And CDC was spending $287,000, a drop in the bucket per year, straight line for 5 years. We had essentially no real program on surveillance, and our legislation created centers of excellence, and all of a sudden now we know the number, at least on the spectrum, is 1 out of every 50. I held a hearing recently on what I call the global developmental disability pandemic of autism. 67 million is one estimate worldwide, but we don't have reliable statistics, and reliable statistics is what drives, I think, good policy. In its World Malaria Report for 2012, WHO suggests that in the 41 countries around the world that account for 85% of malaria cases, it's not possible to make a reliable assessment of malaria trends due to incompleteness or inconsistency of reporting over time. WHO concludes that surveillance systems seem to be the weakest where malaria's burden is the greatest, and states that there is an urgent need to improve surveillance in those settings. And I wonder if you might speak to that issue of surveillance, again, to drive the prioritization, the money, and of course, the deployment of resources.
It's an extraordinarily important question, because if we're really going to invest smartly and if we're really going to get towards this elimination, we need to know with very solid data how to invest and where to invest, and that requires surveillance. And that's part of what we're doing in the new funding model, and I think we're doing as a global community, which is, and really, 10 years ago, you could do anything and have a huge impact because there's so much out there. And that's one of the reasons larvicides don't work in these communities. It's just, there's just too much malaria, and it's not going to do enough. Now we have to be a lot smarter because of the impact, and that means better surveillance. So we are working with countries that by the time they come in with a concept note as the partnership, we will have invested in getting that data and that surveillance data so that we will know how to invest in the most impactful way. It's going to be a process to get there. But I do have to say, too, if compared to where we were 10 years ago in these countries with surveillance to today, because of their work, because of our investment, because of our partnership, it is night and day, and you've seen it. Sir, I know, Mr. Chairman, I know many of the members have been and seen the radical transformation that's occurred that the American people have partnered with people of Africa to do. And part of it is in surveillance, but we are getting there in a way that was inconceivable 10 years ago, which is why I'm much more optimistic than the models, because none of the models would have predicted we'd be today where we are today. And that's really because of the leadership of countries like the United States, but fundamentally because of the energy and people in Africa who are now looking to the United States and countries that have supported them in these diseases in a much different way, in a much more positive way. And as we continue to work with them to support them to identify their pockets with surveillance and improve their systems more broadly, that just expands and expands.
Thank you. On April 19th, Dr. Thomas Frieden testified before our subcommittee and the title of our hearing was Meeting the Challenge of Drug-Resistant Diseases in Developing Countries. And I know, obviously, your global fund deals with PEPFAR type HIV/AIDS as well as with tuberculosis. And he did focus on MDR and XDR-TB and all the challenges that are being faced going forward. But he did spend some time talking about artemisinin resistant malaria and pointed out, and I just quote in pertinent part his testimony, since 2008, malaria infections in parts of Southeast Asia have been shown to be resistant to artemisinin drugs. This is the last remaining class of antimalarial drugs and forms the basis of malaria treatment around the world. If these resistant parasites were to spread to sub-Saharan Africa, which has occurred with other forms of drug-resistant malaria, the results could be devastating. Could you speak to that?
First, I would completely agree with Tom's assessment, and we've actually talked about this. I would point out that there actually is several new classes that are being created through remarkably brilliant public-private partnerships. The Gates Foundation is heavily involved. The Medicines for Malaria and Vaccines is involved. So we will have new classes of drugs, but we can't keep doing that, right? So we need to stamp out the resistance. And that is why we are investing $100 million in that region to jump on it right away, working with partners. It's estimated that it'll cost about $400 million, and we're basically leveraging. And we're looking for people in that region who are interested in those countries to step up financially as well, and then coordinate across the countries, because it is a cross-country effort. It is a regional effort because we have 3 countries that have the resistance. So we are jumping on it immediately because of the threat. MDR-TB is another big problem, and the Global Fund is the largest funder of MDR-TB, external funder of MDR-TB programs in the world, so we're very active there, but that's another committee hearing, so I'll
Let me just ask Dr. Dybel, early on, and I have raised this repeatedly with the Global Fund, and I'm not the only one, it had excluded or largely excluded faith-based groups. I know that there is a renewed effort to try to be inclusive, if you might want to speak to that. Also, the challenges you face. The Global Fund's website indicates that malaria is the greatest cause of illness and death in the Democratic Republic of Congo, and that there are at least 10 million cases of malaria per year. And yet some of their programs get unacceptable ratings, and of course the challenges in the DRC are huge. The war, I've been to Goma myself. I know how the terrorism is and the sexual violence is almost without precedent anywhere in the world. But if you might want to speak to that as well, and then I'll go finally to my colleagues because we do have a vote.
So on Congo, it is a difficult place, no question about it, but you can actually get things done even in difficult environments. And Sudan actually has universal coverage of bed nets. So it is possible. And we're intensively focused on Congo right now, and it's by working with more than the government. That's how you get the job done, by working with partners, including faith-based organizations, which is a segue into your other question. we recognize that you cannot succeed, and then particularly when you're talking about getting to the last mile, getting to the people, and make sure they stay in services and use their bed nets and use the right anti-malarial drugs, that the communities and the faith communities are critically important to that. We have changed the way we operate in a number of ways. We do have quite a number of faith-based implementers, Catholic Relief Services, World Vision. We also work with the faith community to raise additional resources. The large Lutheran group and Methodist group are actually trying to raise $40 million around malaria control right now with us. But it's also about implementation and engagement. And so in our new funding model, we actually have shifted the process around, and it was always intended that faith-based communities be part of our country coordinating mechanisms, but it didn't always work well. And through our new mechanisms, we're actually working on that more and more, and actually welcoming people into our dialogues that lead to a country plan from all walks of life. And we're actually working with faith communities here in the United States to identify in these countries who should be at the table, who needs to be engaged in the conversation. Now, that doesn't mean we have to fund them, but they need to be part of the conversation and part of the national planning, because they do so much on their own. Even if we don't funnel money to them, they need to be part of the national plan and the national approach to ensure that we combat and actually ultimately eliminate malaria.
So what you're saying, let me just follow up on that. So what you're saying is, with these faith-based groups, there is no, in your matrix, when we were talking about funding matrix, there is no disqualifier in terms of providing funding for that?
Absolutely not.
Okay. And as we know, in Africa, it's either faith or it's tribal or cultural, and so you're reaching out to all those different groups and the leaders of those groups to make sure we hit these pockets.
We are, and our new funding model actually is designed to ensure that we do that in a much more aggressive and effective way.
All right. Well, I yield back. I thank you, Mr. Chairman. Thank you for your testimony.
Thank you. Anybody else like to make any final comments? Ambassador Dybel, would you like to make any final comment?
I'd just like to thank the committee again, and thank you, Mr. Chairman, for your many years of leadership, and look forward to continuing to work with all of you.
Well, frankly, we want to thank you for your extraordinary leadership, lifelong. You have made an extraordinary difference, and I know it because the passage of PEPFAR was in no way a done deal. It's reauthorization, which greatly expanded. It was a lessons learned, and again, you were critical in the drafting of that legislation. So you have made an impact and saved lives that really deserves a great deal of praise. So thank you for being here. Thank you for the work that you do. And this hearing or briefing part of the hearing is adjourned.